I'm Mike Jackson. I'm chairman of the Jawbone Pathology Committee here with the IAOMT, and it's my pleasure to introduce our two speakers for the first breakout session. Dr. Phil Mollica, DMD, and Bob Harris, DDS. Their topic is current trends in ozone oxygen therapy in dentistry. Dr. Mollica graduated from the University of Medicine and Dentistry of New Jersey in 1983. Prior to dental school, he received his master's in human anatomy at Farley Dickinson University and received his doctorate of integrative medicine in 1999 from Capital University in Washington, D.C. He's author, researcher, national and international speaker on topics dealing with integrative medicine and its application into biological dentistry. Dr. Bob Harris graduated from dental school, University of Louisville, 1971. Served in the U.S. Army Dental Corps from 71 to 73. We thank you for your service. Was also on the faculty of Louisville in 1973. Graduated from Capital University of Integrative Medicine in 1999, and then went back and was on the faculty from 2000 and 2005. He is co-founder of the American College of Integrative Medicine and Dentistry, and with Dr. Mollica teaches the course on oxygen ozone therapy in dental medicine. It's my privilege to introduce both of these. Greet them with a warm welcome, please.
Today is two things. Bob's going to start out, give you a current status where we are with oxygen ozone therapy in dentistry, a quick overview, a very simple overview. And then what we're going to do is talk about bisphosphonate therapies, and we've been working on that for the last 2.5 years with therapies, and everyone should be very, very aware of what's going on with bisphosphonates, how it's affecting the jawbones. We're going to talk about the pathophysiology and our treatment methodologies that we've developed over the last couple of years to help minimize the damage and eradicate it if we can. With that, I'll turn it over to Dr. Harris.
Thank you very much. Thank you very much.
Thank you. You can hit that button.
Okay.
We don't have any automatic.
So, Phil and I always have developed this lecture technique where we it's a tag team thing, and plus, in the courses it's stop and ask questions as we go, as a lot of you all in here know from taking the course. So, unfortunately, we only have 45 minutes to go through this material today. So we'll go through it and give you all kind of an overview of what's happening lately in dentistry as far as ozone goes. We've trained over 200 dentists now, and some physicians and osteopaths, and a few nurses in dental ozone and in the medical component of it also. We're really looking to integrate oxygen ozone therapy into your practice on a daily basis because it has so many applications and it can do so many things, not just for you, but for your patient, and to keep them from bothering you with sensitive teeth, with root canals that are blowing up and things like that. So, do you want me to get more over here? Okay. Thanks to the efforts of Rich Fisher and some of his cohorts and Dr. Mollica, we now have malpractice coverage and for people that want the malpractice for the ozone treatment that we do, and that's available. Some of our own malpractice coverers will cover your ozone therapy in your office if you're on an institution review board, which we have available. But that's individually kind of the thing with each individual insurance company, so you got to check with that. We use scientific review approval. The IAOMT has given us the scientific review committee has given approval for using ozone through the academy with dental medicine and everything that you do as far as operative dentistry, and then also a specific area of endodontic treatment. We also have that approval. What we really took off on when we developed the American College of Integrative Medicine and Dentistry was we wanted to make sure that we had an entity that would live past us and would have approval by Health and Human Services at the federal level that would allow this research to be ongoing. So what we did was we set up through Health and Human Services, the American College of Integrative Medicine and Dentistry, and using the ADA guidelines, we're setting up the research as an evidence-based dentistry program through what are called practice-based research network. Have you all read in the ADA journal? I mean, how many people are in the ADA anymore? Anybody? Okay, so, in the ADA journal, I would say in there, EBD, evidence-based dentistry, practice-based research. Anyway, that's what we wanted to do, was get something that if we do this and like someone is involved, with the research that we're doing, and you want to be like totally certified, and that's what we do the training courses for, is to make sure that anybody that wants to do this in an orderly manner can participate. If you don't want to, if you want to use the Ozone for, ozone trays and perio and in localized topical applications, is it important to be a part of the research? Probably not. We basically developed that from the standpoint of a protection for people that wanted to go into the deeper areas of infection in dentistry, like the osteocavitation and the necrotic lesions that we get into. So, keep talking. Keep going. What was my next point on there, on that slide? So, that's kind of where we are right now. Farrah, is this going to be like Farrah Fawcett thing coming up here? They'll pay more attention to that than me, I'm sure. Tell a joke. Okay, let's see. Phil and I are really funny most of the time. Okay. Well, we have the classes, and they're a two-day seminar, and we hold them at Phil's office in New Jersey, or we also hold them in remote locations at other people's dental offices. We've held one at Ulof Grant's office in Santa Rosa. We've held one at Mitch Martyr's office in Seattle. A lot of the West Coast people don't like to travel to the East, so that's what we've been doing, is making these other courses available at other places. So, and it's a two-day course, and it basically breaks down into the history of oxygen ozone. How did this come about? Who really discovered that this was good? In 1925, Otto Warburg in Germany was doing research on oxygen and the oxidative phosphorylation in mitochondria. Warburg is the guy who trained Krebs, who comes up with the Krebs cycle. So Warburg in 1925 found out that cancer won't grow where there's oxygen. And so he does all this research on it, and he finds that, well, golly, it doesn't. And so he then puts all of it together, and in 1931 gets a Nobel Prize for finding that cancer won't grow where there's oxygen. And so then in 1944 he got another Nobel Prize for finding cancer has a predisposition for areas of fermentative metabolism, where there's an anaerobic metabolism going on. And so Phil and I were exposed to ozone at Capital University of Integrative Medicine when a naturopath that was teaching there brought in a protocol to show us how to cure ear infections. And so the first thing he did was put ear candles in everybody's ears. If you're familiar, they look like little cotton candy holders, So he put it in there and would set it on fire, and we're like, oh, this is really good. We're really going to do this. And so then after he did that, he brought out the little suitcase like we have next door in the exhibitor room, and in there was a little ozone machine. He said, now we got this vortex open, we're going to put ozone in your ears, because then it's going to go through the tympanic membrane. You're not going to have any more ear infections. Well, I knew ozone was toxic, and I wasn't going to have any of that stuff in my body, and so, but eventually we did it, and then that was 1998, and we went on with it and found out that it was a really good way to eliminate all these pathogenic organisms, especially that we see in dentistry. So, and internationally, we've trained people, Germany, Italy, Brazil, Mexico, Australia, Canada, India, Malaysia, and those people are working with us as far as developing standard of care in oxygen ozone therapy and dentistry. In January, we had Dr. Lamberto Ray, who's an MD from University of Ancona in Italy. He's a medical MD pharmacologist, and he started the first ozone medicine program at the university level in Europe at the University of Ancona in Italy. And he taught 2 weekends with us in January here at Phil's office. And we're going to try to put together an international congress on oxygen ozone therapy and hold a meeting sometime in 2010. We're working with some other people on that right now. So what are we doing with this currently in dentistry? Well, you can do about anything you want, but to get rid of infection, which is the big thing. I mean, if you can get rid of the biofilm that causes the problems that we deal with perio and with decay on a daily basis, how much benefit is that going to be for the patient? So you can treat a decayed tooth. When you treat it with ozone, you'll get almost like a frosty etched look on the tooth. You can treat infections of the head and neck. You can treat perio, do endo with it. Endodontics is unbelievable. The root canal specialist in my area, the endodontist, he was opening them up. I was putting ozone in them. We were shipping them back and forth for 5 years. He calls me about 6 months ago and he said, okay, I'm buying an ozone unit because I've never had a tooth blow up after we treated it with ozone. And so, but he had been using his standard protocols, but every tooth that I sent to him, I made sure he sent it back to me so we could put ozone in it. And he said he'd been following along. He said, that's it, I'm done. We're doing ozone in all of them now. Enhanced wound healing with post-surgical problems. You can get soft tissue lesions, bony lesions. This lesion you see here, that's a bisphosphonate lesion. Phil's going to talk about that in a minute, but all of these real weird new types of infections that we're getting. And the ozone trays that we make are really good for enhancing your prosthetics and decreasing root sensitivity and just giving you better longevity out of your restorations. So what are we looking at from a physiologic standpoint? And how are we going to use ozone in dentistry? We're going from an anaerobiotic environment where you get the anaerobic organisms are just having, party time down in the periodontal pockets, underneath alloys, underneath restorations. And so, but what we want to do is affect an ecologic shift from the anaerobic acid-loving environment over to an aerobic environment. And how do you do that? Well, ozone is the third strongest oxidant out there after fluorine and persulfate. Ozone is very negatively charged. Inflammation in infected areas are positively charged. So you have a natural physics of drawing the ozone molecule into the area where it's needed. And as a benefit, all healthy cells have the enzymes in them that will protect you from an oxidant like this. So they have their normal antioxidant enzymes: cellulase, catalase, glutathione peroxidase, superoxide dismutase. Those are all there. So when the ozone shows up, here's a healthy cell. It's okay because it quenches that reaction. Here's a pathogenic cell, no antioxidant enzymes. It punches a hole right through them, and they're dead and gone. Any unhealthy cells around are also broken down, so it kind of cleans the area up. So you're shifting that from a pathologic environment to an aerobiotic environment. And so you're getting rid of the mixed infection. It doesn't matter whether it's bacteria, virus, or fungus. It's going to be gone. So quickly reviewing, what do we do? Well, if you see an area back behind where a third molar's been and they're having pain in that area, you can actually go into that soft tissue area back there. A lot of times the needle will just penetrate right down through and into the area of bone, and you inject ozone in there, put gas in there. What's it going to do? It's going to kill everything that's in there, disinfect the area. And ozone, because it diffuses so rapidly into tissue, it will create stem cells in the area, and you'll grow new tissue in there to replace the tissue that was being broken down by the bacteria. If it won't go in that easily, like with a needle, you can take and put an X-tip through. Just take and drop it down in there in that anesthesia type system, and you just put your needle in there and inject ozone down into that area. Or you're going to put it in a root canal. This is what we do. We just take like a needle and put down in there, and you just slowly inject ozone gas in there, and it permeates out into the dentinal tubules and all the lateral and accessory canals, and that's where the problem is anyway. That's where the bacteria, virus, and fungi live. This is a quote from Dr. Ray's lecture to us back in January, and Dr. Ray being Italian and trying to translate into English, but this is his direct quote, that pharmaceuticals in the gaseous state are exceptional. So he's talking about like the chloroforms, the gaseous things that you'll use in anesthesia, and that they penetrate and get in the body a special way, and that they're not injected or ingested. So special forms of application are required. That's why we use an X-tip to get ozone into the bone. That's why we use the maxi probes with the side bending cannulas to go in periodontal pockets, because the maxi probes are rounded on the end so you don't damage the tissue when you're in there. And so we apply it in a special way. And we use the oxygen as a generator gas for the ozone, which is the oxidant, which kills everything, but it's only at a very small amount, 0.05 to 5% volume. So we're using a very minute amount of ozone. You just don't need a lot in there. And the rest is oxygen. And so you've got two natural ingredients. What happens is when you're making ozone, you see the little lightning bolt there. It splits an oxygen molecule into two singlet oxygens. They join up temporarily with O2 and form O3. The O3 reacts immediately when it hits tissue fluids and breaks down, and your breakdown products are not a problem because it's water and oxygen. So the oxygen in ozone is not metabolized, so it's not a drug. You're not taking it and saying, oh my gosh, the liver's got to break this down and it's got to take this and move it out. It doesn't. It's just used by your body naturally, because that's nature's antibiotic. Think of all the pathogens that we have. Most of them are anaerobic. So it leaves no byproducts or residue. It leaves water and oxygen. So the resultant of that is it stimulates the organism's natural and inherent processes, and you re-regulate your whole system when you do that, and you get homeostasis. So what are the properties of oxygen ozone therapy? It kills bacteria, virus, fungus, and parasites. It disinfects and sterilizes. And it does it rapidly and with no bad side effects. The only thing you have to worry about ozone is people say, oh, well, you can't do this, you can't do that. There are two tissues in your body that are not protected with enough antioxidant enzymes to quench the ozone rapidly, and that's your eyes and your nasal membranes. So that's the only two areas you have to worry about. So you don't want to take a big whiff of it, and you don't want to let a lot of it get up in your eyes. Does that happen in the operatories where we practice? No. Because you keep a little fan running when you do some of the procedures, and just keep it circulating in there. So therapeutic dosing, you express ozone in micrograms per milliliter of oxygen. And so we're using about 6 micrograms to 30 for internal use, meaning we're injecting it into soft tissue where there's infection, and external use where we're doing like periodontal therapy and root canal therapy. You can use a little higher dose. But you always start low with a low dose and go slow and just let the system recover. And so we use site-specific infusion, and you get a physiologic response. And this is what Dr. Ray has been working on in Europe. And this is interesting in that now we're finding that we were just generally injecting ozone, like I use it in the TM joints a lot and trigger points. Now we're finding out how to do it in site-specific areas and how deep do you go. A subcutaneous infusion elicits a vascular response and brings more blood to the area. We really are just finding out some of this new information. Subdermal infusions, about 13 millimeters deep, you get an antioxidant response in the body. It upregulates the body's inherent antioxidant systems, and so the body requires a small oxidative burst in order for their own inherent endogenous antioxidants to form. And that's what you get. And then if you want a true anti-inflammatory injection, you go slightly deeper, 15 to 20 millimeters deep, and inject intramuscularly, and that leaves you with a permanent anti-inflammatory effect in those muscles, which is why we see such good results when we use it in trigger point injections. And so the philosophy of head and neck oxygen ozone therapy, again, you're going to start low dosage and go slow. And you inform the patient, what you're doing and everything, and we're going to support healthy tissue while we do this. We have what we call initial foundational therapies and clear pathways for drainage. So a lot of times in these areas we'll inject, before we inject ozone, we'll put in a little injection of procaine, B12, folic acid, Traumeel, Zeal, something like that, to precondition the tissue for the ozone when we put it in there. Then anything that you carry in with your first injections that you would might pick up off the skin and the needle and the lumen of the needle, when you put ozone in there, that's that. So you never worry about getting any infections at your injection site, because you're creating a sterile site where your injection actually goes. So, and we're actually looking to eliminate the foci of infection and disease with this. So that's the big thing that we want to do. And the preconditioning therapies, we go in and we'll inject the pterygoid plexus, and this is like where you're going to go in and do a posterior superior alveolar block. You'll inject back up in there, and you leave the ozone up in there. There's a big plexus of vein up in there, and Phil came up with the concept that if we put the ozone up in that pterygoid plexus, so often you do a posterior superior block and you'll get a little bleeding and maybe a little bruising. The ozone will actually be picked up in the circulatory system of the whole head and neck and start disinfecting the whole head and neck. Tonsils are big. Some people are a little bit hesitant to inject them, but they're really important in people that are really sick and immune challenged. And you can inject the tonsils and knock out a lot of infections in the tonsils and upregulate your immune response. We have a 9-point lymphatic drainage protocol where we inject the lymphatic superficially, so we'll get good drainage out there. And we use nasal and ear insufflation. So you're going to breathe. You can breathe ozone if it goes through olive oil first, because it changes it from ozone to ozonide. And ozonide is not an oxidant like ozone, but when it hits the lung alveolus and transfers into the water of the tissue, it converts back into ozone in the bloodstream, so transiently. And ear insufflation is really good. Like I tell you, that's the very first thing that we found out that it was good for. And so in these 2 journal articles, there's tons of information out there now on ozone. It's confirmed that controlled ozone administration promotes an oxidative preconditioning or adaptation to oxidative stress. And so what we're doing is taking a very small oxidative burst and making the body more responsive to when it gets beat up by the stuff that hits us every day. This is from Dr. Bocci's book, and it just shows that ozone goes in, reacts immediately with the plasma, and forms reactive oxidative species, which is the immediate response up here, and a delayed response, which are lipid oxidation products, LOPs. And if you look under bone marrow, and this is research that Dr. Bocci did, you actually get erythrocytes that can carry more oxygen, and you get a release of stem cells. And that's what we're looking for now. So how are we going to get, why do hips regrow when they inject ozone in them? Where does the bone come from? Well, what happens in all these areas? What happens when you inject the TM joint and suddenly you look in there and things are getting better again? It's because of this release of stem cells, because you're building new cartilage and new bone at the same time. And we cover all those areas pretty well in the course. Here's the average number of articles per year relative to ozone in medicine and dentistry. 1997, there were 466 articles. 2007, 726. So there's more and more articles being published all the time. And then when you're going to, you see the number of articles relative to ozone clinical trials. You can see the little pie chart here, and the 247 papers on clinical trials, and 97 there were 2 articles. In 2007, 98 articles. And these are all clinical uses of ozone in medicine and dentistry. So what are your main target diseases of ozone therapy? Well, your main target organs over here would be skin, heart, eyes, liver, bones, kidney, and brain, around there. And over here, your main target diseases, what is it? The big one, infections. You get rid of infection and inflammation, boom. And then post-surgical. And in Italy, that's what they're using post-surgically almost routinely now in the areas where they're teaching the ozone is ozone therapy for post-surgical problems. And Phil is going to talk to you now about the bisphosphonate issue that we've been dealing with, which is a real looming problem.
Thank you, Bob. Okay. What we want to introduce today is a project we've been working on for the last couple of years, a relationship to bisphosphonates induced osteonecrosis of the jaw. If you don't realize this is a major issue, be prepared. This is going to be as bad, if not worse, than the mercury issue in the next number of years, as we're seeing more and more of these particular, if you want to call it a syndromes, coming out in these jaws. And we've been working on ways to address it in a safe, effective manner because treatment is extremely limited, and we'll discuss why a little bit. I don't want to spend too much time. We spent a little bit more time in the course on this, but basically with bone physiology, I mean, the bone in our body is in a constant state of dynamic change. It really is an ecosystem. An ecosystem that has a lot of chemicals, cytokines, information come from different parts of the body, and a dynamic change in the bone. There's always a balance between the osteoblasts, which create bone, and osteoclasts, which take away bone. It's a constant ecological dynamic. Bone is not rigid and hard. Bone has a great ability to bend and flex, and this is part of the issues that we're seeing with the bisphosphonate. So, bone is a constant state of dynamic remodeling. It's a dynamic state, an environmental, ecological condition of 3 cell types: osteoblasts, osteoclasts, and osteocytes. Osteocytes are osteoblast, bone-forming cells that become encased in osteoid and become part of the bone. So osteoblasts become osteocytes. So the function of bone, of course, we know, structural with calcium metabolism, and once again, osteocytes are osteoblasts encased in bone. And of course, bone remodeling is really a careful coordinate, interplay of osteoblasts and osteoclasts. And of course, the osteoid is the organic matrix that's laid down by the osteoblast, or the osteocytes, and then eventually we get crystallization of the minerals coming into the bone itself. And the difference between osteoblasts and osteoclasts, I mean, we don't want to spend too much time here. But, once again, one creates bone, one takes away bone. But the most important thing is that there's a constant line of communication between these cell types. It's an ecological balance that keeps our bone sturdy and healthy. Remember, osteoporosis, jumping ahead, is really a nutritional issue, okay? It's a nutritional issue where our GI tract is failing, but that can be corrected. And of course, bone physiology is made up of bone matrix, collagen protein fibers impregnated with mineral salts, and calcium phosphate, calcium carbonate, calcium fluoride, and magnesium fluoride. So fluoride sneaks in a different form. But those are basically the mineral contents or the makeup once this organic matrix is laid down. And here's some nice normal histology looking at osteoclasts, which are really multinucleated type cells. They are very interesting and very dynamic. They have a very important, obvious role in bone metabolism. And what's called a bone metabolic unit, which is made up of osteoblasts, precursors, connective tissue, blood supply, that lays down and makes our bones. It's a beautiful system, perfectly balanced, making a wonderful skeleton that we can function with. And here's a great physiology book picture. If you have your osteoblast precursors and then they're called upon, well, a little osteocyte's getting tired, he's laid down too much bone. Let's bring our osteoclasts in, clear out that matrix, and allow the new osteoblasts to come in to turn that bone over, to keep us healthy, well, and moving along nicely. But then here in this nice picture, we see where there's an interplay. Once again, I keep stressing this balanced ecology between the cell types, the osteoblast and the osteoclast. Once again, our osteocytes are nothing but osteoblasts encased around that bone matrix. So there's a real interplay between pituitary thyroid hormone, vitamin D. There's a whole complex of information that goes on. It is a balance. And we can see here in the maturation of osteoclast, the osteoblast stromal cytokines, and cytokines are chemistry. It's chemical language. And this is the biggest problem with bacteria. We'll talk about perio tomorrow in detail. But the biggest thing is with all these mixed infections we have in the body, they all speak the same language, and the language is chemicals, cytokines. But here we have a hemopoietic cell, nice and happy. The body says, listen, I need some bones taken away. So the signals go out, all this lichens, all this information, everything starts to change in dynamic. We're becoming more differentiated. And then these multinucleated precursor osteoclasts form together to what's a quiescent, relaxed, multinucleated osteoclast, ready to do its job, lay on that bone, dissolve it, change it, so we can get a nice new skeleton. The information comes in, now we have an active osteoclast. Well, single cells are very interesting. It's an epithelial-based type cell. But look at the chemistry. This always marvels me of how much information and things go on a single cell. It's just not as simple as just drops in and dissolves some bone, goes out. There's a whole dynamic. There's a whole system going on with this nice, happy cell doing its job, what it's made to do. What osteoclasts do, they settle on the bone matrix, actually hook on with these things called integrins, lock down to the bone, and they actually start pumping protons, create an acidic environment which dissolve the crystal matrix of the bone, leaving behind the organic matrix, which is dissolved, and then once again freeing up the old osteoblasts, so the old osteocytes, so the osteoblasts can come in and turn, so that dynamic is going on. It's a balanced ecology. So this is quite the dynamic. And once again, you see here a simple representation of how mononuclear cells come in. They're speaking to each other. They differentiate to the different type of cell types. Lay down, take away bone. New bones lay down. Osteoid, which is the matrix, and then it matures, calcifies, brings and mineralizes, and we get a nice change of the bone. And this is kind of what goes on normally. Your healthy, happy bones. Well, now came up the great idea. Develop these kind of drugs that we use in cancer therapy, but the side effect was, wow, we were getting denser bone. But in reality, the reality of getting denser bone is, well, let's kill the bone and it will look denser for you. So we're saving our bone by killing it. How are we doing that? Well, we developed this class of drugs called bisphosphonates. Now, years ago, we had a problem with phosphonates. They used to call it fuzzy jaw. And my partner, Bob Harris, I think is old enough to remember those days. I know Phil Sukul left. I was going to pick on him for a minute. I know Mike was there. But anyhow, they used to get fuzzy jaw, phosphate poisoning. And the jaws, the people literally lose their jaws. So what happens, the old term was diphosphonates, and of course, they're related to what's called pyrophosphates that we find in our toothpaste. That's packed with fluoride too, so less poison to little kids too. Anyhow, so it's of course used in radiology, a bone-specific radionucleotide. But the interesting thing about pyrophosphates is that they can be broken down by a process called hydrolysis. That's how your body works, using water as a solvent to break things down. Well, that's fantastic. Well, let's go into the biochemistry in the organic lab, and let's try to change it and change the chemical composition or backbone of the molecule and make a bisphosphonate when they had the carbon substituted for an oxygen in the backbone of the molecule. Now it becomes completely resistant to hydrolysis. It cannot be broken down by normal means. So that drug cannot be broken down by normal means. The result of this fine chemistry is that there's an accumulation in bone and a very long half-life. In reality, by taking these drugs, so when Sally Field gets on, I only have to take this once a month. Well, she's salting her bones very well with bisphosphonate, and she's creating a situation that will certainly be lasting 10, 15, or 20 years. So in other words, you take this drug, you are really in bad shape for the next 10, 15, and possibly 20 years, as we're seeing with these. So you just stop it, I'm okay. No, you're not. So by adding, other cool things like nitrogen side chains, let's increase the potency of the drug so we only have to take it once a month as long as you can sit up and not move. Yeah. Okay? So we increase the potency and the toxicity. And of course, you know, when we start in the early days, we got direnol with a short alkyl and a relative potency of 1. But as we move along and became more and more sophisticated, we came from, you know, taking pills to IVs. You know, we've seen the famous names Fosamax, Actonel, Boniva, Iridia, and Zometa. Now, Zometa has a relative potency in relationship to the original ones of 10,000 times more toxic and longer lasting than the original drug that was developed a number of years ago. So now we've gotten much better at that. So what we're seeing now, of course, in these IV protocols, which the idea was, once again, give these bisphosphonates and it will slow down the invasion of cancer into the bones. Well, obviously, IVs will certainly salt the bone very quickly. But now we're easily seeing this area with the oral bisphosphonates, because how many years are these people been on this drug? A long time. And this is why you're going to see a massive increase in the problems we're having in the jaws. So now we're a number of years down the road with oral bisphosphonates. So why? So what's going on here? The reality is that this bisphosphonate actually salts on the bone. We are producing physiologically, normally, our osteoclast, but they're coming in, they're ingesting the bisphosphonate, and it's poisoning them. So therefore, what's happening? We're not getting reabsorption of the skeleton. Our poor little osteocytes are very tired. They want to get relieved. They want some new next team to come in. Can't get out of the bone. And what do osteocytes do? Well, my job is to make more bone, so they continue to make more bone. And that gives you a false impression of what? Denser bone, because they're not relieved. So histologically, we look at bisphosphonate-induced osteonecrosis, we wind up seeing these lacunae that are blighted. They're totally broken down. The ecology has shifted. Versus our normal remodeling shown the BMU, bone metabolic unit. Slight difference. And these are the things, excuse me, you should be looking for in dentistry. The pathophysiology, the fundamental biologic action, inhibit bone reabsorption. Therefore, we stop bone turnover. The effect is inhibition or irreversible cell death of the osteoclast. The bisphosphonate functions as an analog to isoprene diphosphate lipids. It blocks the enzyme systems even for apoptosis. Now what happens, the cells immediately apoptosis, which is popping and death. And the result is, ultimately, is old bone that is not removed, new osteoid not formed, old osteocytes eventually die, leaving behind hypermineralized bone. With hypermineralization comes fragility. It's very rigid type bone. And this is what you have to do. When you do your wonderful, hopefully digital radiographs or whatever radiographs, you have to look around the lamina dura. This is the result of 4 years of oral bisphosphonate. You're going to see condensing around the dentition. And you'll see this. But you see in patients, they come in, what kind of drugs you taking? Nothing. You're not taking nothing. You're taking nothing? You're taking, you know, that osteoporosis drug? Yeah, but what does that got to do with dentistry? Okay? When you take your radiographs, look for this. This is what you're going to see. So this is great. Where oxygen ozone is a little bit different. I mean, we have side effects, of course, and I won't go through them, but one of the forms, of course, is jaw osteonecrosis. But it's interesting, the physiologic effects. Decreased bone reabsorption, decreased bone formation by 70-95%, increased mineralization density, slight increase in bone volume, increased bone strength for the first 5 years, then you fall off the cliff. Decreased fracture rate for the first 5 years, half-life in bone greater than 10 years, that's really changing dramatically. Increased microdamage in animals and long-term effects of bone unknown. Okay, that's good. Basically what's happening, we're winding up with old skeletons become extremely brittle. Over the next few years, you're going to see massive jaw problems. You're going to see spontaneous fractures of the back and hips. This is what's going to happen in a very fragile, glass-like skeleton. So when a patient comes in with their implants, and this is what you see, you know you're dealing with really a dead bone issue. You're getting denuding of the epithelium. and exposure of bone. Gee, that's a difficult problem to deal with, and we'll explain why. But the reason why, and this is just a hypothesis at this particular point, the metabolic rate at the alveolus is much higher than, let's say, the tibia in this particular case. 10 times the rate of tibia, 5 times the rate of the mandible, the inferior alveolar nerve, and 3.5 times that below the inferior alveolar nerve. Okay, so we have a higher metabolic rate, but also, listen, the mouth is trauma drama city, infection city. People are chewing all kinds of craziness, making little puncture holes, normal stuff we do, putting screws in your head, and that's an open system, so you're susceptible to this type of infection and dead bone. But I understand some of my colleagues were telling me that, I understand in the perio worlds that they think the dead bone's okay to put screws in. I forgot who told me that. But this is some of the things that you will see. These are other type of lesions that you see. The problem now we're dealing with dead bone. Now, we've dealt with dead bones with the cavitational issue for a number of years, but the difference has been is that at least there was a sealed system in a way where the soft tissue covered this area, even though we're dealing with a foci of infection. This is where Ozone's worked very well in these foci of infection because at least it's contained and sealed. What happens typically here through trauma, extractions, biting of one's cheek or the gums, the soft tissue itself becomes denuded and peels back. The periosteum breaks down and you wind up with raw open bone. I do oral facial pain at one of the university medical centers at home. We had this one meeting with all the oral surgeons, a lot of excitement. We're all to the assets. Hey fellas, what are you guys doing about the bisphosphonate issue? Oh, we just had a big meeting on that. Oh, great. I says, well, what are you doing about it? Oh, we're doing nothing. I says, nothing? You got dead bone. He says, well, people can chew on dead bone. I said, we're just putting them on Paradex for life. And I says, well, we can fix most of these with oxygen ozone. Over their head. That's another story. Anyhow, so these are the type of lesions you have to look for. You're winding up with denuded bone, exposed dead bone. Very complex and difficult to deal with. And it is coming. Yes? 3 minutes? Okay. I got about 20 more minutes, but hang on, guys. I'm working hard for you. Anyhow, the problem is superinfections. These are open systems, and we're seeing more and more where we're winding up with multiplicity of superinfections. And as we well know in the mouth, there is not one type of bacteria. It's a colony. Once they set up shop, they send out messages, hey, everybody move in. Let's go. So you have multiple dynamic type of infections going on. Viruses, fungus, bacteria. This is a hell of a thing to deal with. And you put them on antibiotics for 6 months. They get all kinds of patients coming in. They get sick from the antibiotics, the antifungals, the antivirals. So that kills them before the bone does. Anyhow, so this is the kind of cool thing that you'll see in the future. Death, half-life, of course, once again, 10 years plus. There's no way to repair the bone because the ecology has been totally shifted. Half the population of your bone cells have been killed. And you're getting soft tissue sloughing, exposure to necrotic bone. It's an open system dealing with chronic infection. Antibiotics fail. Why do they fail? Those drugs fail. It's an avascular issue. You can't get this stuff into the system. Okay? And surgery, as they found out, makes it worse. Early on, a number of patients we see, they went in and had to have a tooth extracted. They were on the drug. Nobody knew what was going on. Tooth extracted. Patients in problems. They come back the following week. Oh, that looks like a dry socket. So what do? You drill it up. Come back the following week or two. Not any better. Send it to the oral surgeon. What does the oral surgeon do? Cleans it up. And you wind up these massive holes in the jaw, as we learn from experience. And this is what you wind up, and we'll see more and more of these type of situations in the future. So the current forms of treatment do nothing. Stop the bisphosphonate treatment, which is ridiculous because you're screwed for 10, 15, 20 years. Intermittent exposure, that was another cool one. Antibiotics up to 6 months. Debridement site is avoided. Basically do nothing. Oral disinfectant rinses, which is ridiculous. So we're using oxygen ozone therapy and cytoprotective therapy. Cytoprotective therapy making up little simple cocktails of procaine, B vitamins, and homeopathics to prepare the area for the infusion of the oxygen ozone. So our goals, using oxygen ozone, we want to eliminate the infection. We want to support our tissue. We want to get metabolic re-regulation, drainage, stimulation of stem cells, necrotic tissue sequestering and elimination. And that's an interesting thing that will freak you out the first time. And reepithelialization over the soft tissue. This is one of the key elements to get that tissue back over that bony site. What we've done is develop some protocols, and we spend obviously a lot more time than 3 minutes on this. But the first goal that we do at oxygen ozone therapy, we can go right to the focus of the infection. We eliminate the infection elimination is first on the runway. We have to get the infection under control. And we use a multiplicity of things. We use oxygen ozone with infusion, we use an ozonated water, and we use an ozonated oils. We use cytoprotective formulas infused in and around the vascular area. Now, the beautiful thing about oxygen ozone and even ozonated water is there is a direct correlation to infusion of oxygen ozone in the water state and the gas state to nitric oxide. There's a direct proportion of nitric oxide formation. And what does nitric oxide do in the body? Opens up what? The vascular beds. So now we're stimulating blood flow back into this area so we can start cleaning it up. Got to help the body get this moving. So we use ozone water lavage in and around the site. And you can expect pus for the first, couple of rounds there. But then what happens is you start to see actually blood start coming out of these wounds. And then we circle the drag and do a couple of different type of injections using oxygen ozone at a low microdose. And then we can continue therapy. In some of these cases, took up to 6 months to get under control. And epithelialization is a critical factor in addition to sequestering the necrotic bone. Sequestering necrotic bone. First time this happens, I'm working on this gentleman and prostate cancer, big problem with the bisphosphonates. We've been working on getting the infection under control, and it's a hole. You'll see these holes in these people's head with bones sticking out like you saw before. So I go up there to do my normal irrigation. I see the bone move. That's all of a sudden you go, what's that? Okay? And I go back, okay, oh man, the bone moved. What happens in the body's innate intelligence, it actually cleaves off the bone. And we have an oral surgeon out in Santa Rosa working with us too. You're seeing the same thing where the body just gets rid of this dead bone. And once that occurs, and these bad ones, the tissue approximates itself, and then we get that nice healing effect, which is fantastic. But we continue to support the patient. So even as an adjunct in therapy, we do use, tray therapy, which is a wonderful thing, and I'll talk about that in detail tomorrow with perio. We tray therapy in the office and home care. In the office, we use a total saturation technique like you see here. We have oxygen ozone flow over the wound site. We do that maybe once or twice a week. And we also, at home care, give them another tray. We put ozonated oil in so they can actually soak the area and keep that clean. And home treatment is at least twice a day. And a number of our ozone users out here, and you know how the ozonated water and oils work phenomenally well in their oral cavity. So we support our therapeutics that way. But inevitably, you're going to have to extract. What's important is, if you have a situation where you know you're going to have to take a tooth out, precondition the site. We talk about preconditioning, where we like to do direct and indirect infusions of oxygen ozone into the bony areas of that tooth a couple of times. What that's going to do is, A, increase blood flow to the area. If there's any infection in the area, it's going to certainly reduce that down and stimulate all those biochemistry, all that physiology in the area. So when you take the tooth out, at least you have a good shot of good healing, and that's worked extremely well for us. So in a non-emergency sense, take a week or two, precondition the patient with these ozone therapies and cytoprotective therapies, and I'm telling you, it makes a huge, huge difference as far as healing. Now, as far as emerging extraction is concerned, sometimes you got to get the tooth out, and they're running on these drugs. What you have to be careful is, we normally like to go in there and root that socket. Easy does it. Just get in and gently clean it as best you can. Then you rinse it lavage it with ozonated water. You close the site as best as possible. And then the beauty of it, the real nice trick is, and we use this on all our extractions, you take ozone gas, you use a maxi probe, slip down to that extraction site, and slowly bubble some oxygen ozone gas in there. It'll create a beautiful, beautiful clot, beautiful, nice red clot in that area, and seal that area as best it can. Then place, 1 or 2 cc's of oxygen ozone at the neurovascular bundle, meaning if you're going to extract the lower molar, drop a cc back by that inferior alveolar, be picked by that complex and brought right through the jaw itself. In home care, and this works phenomenally well, even on routine extractions, give them some ozonated olive oil to apply to the site. 3 to 5 times a day. The oil works phenomenally well, and monitor carefully. Another trick we do, we make ozonated water, which you teach you how to do. It's very simple, and we actually make ice cubes out of it. Freeze it and it traps the oxygen ozone in the ice cube, and that can melt and gently keep the wound site very clean. These are some of the funky little things. What's happened with these really super type infections, you see constant oozing. I mean, I have the patients come in that the pus is just unbelievably just pouring out of these wound sites, and that's really the most difficult part. Get that under control. We really get them on a strict program. And you'll see these holes, these subtle holes and extraction sites that were done. And here we see an area that we've moved down the pike. We're actually seeing with the infection cleaned up, and now we're starting to see re-epithelialization of the wound itself. Once we get the wound closed over, the soft tissue back over, we're in much better shape. Is that going to regenerate the bone? The ecology is screwed. But most importantly, we're getting the infection under control and sealing up the tissue and have a better battle. And you'll see typical sites like this where the pus is just oozing up through the wound sites themselves. And here's a radiograph. This is our little bone cleaving. We're up in July. Was it July? August 29th, if I had a pointer. Up in here you see the bone right adjacent to the tooth here. We're cleaning the site up. And then around January, in the beginning of January, the bone actually cleaved itself, separated out, the epithelium re-epithelialized, closed over, and sealed, and we got this under control. So when you're treating with this ozone, you eventually see this cleaving effect coming out, reproximation of the tissue, and then you have some control over the environment. You got to support them. Now, ozone is one thing, and I'll even talk about it tomorrow, but it's a piece of the puzzle. There's a lot of other little slick tricks you do nutritionally, etc., but we just want to focus on this one little particular point on using this nice disinfectant. So the bottom line is you have to be diligent in your therapy, support the patient, forget about time. It's not like doing a filling that's all over. Patients will have little or no options. They have no options. You can't live on antibiotics, fungals, virals. It just is not working. You incorporate some basic nutritional therapies. Don't give up. And of course, the reality is, gang, the storm is coming on this. This is just the beginning of the whole shebang.